All right, we'll go ahead and get started. So, welcome everyone to our Health Disparities in Medicine series. Tonight, we'll be talking about infectious diseases and sexually transmitted infections in the minority population. My name is Dr. Olutayo, and along with the SNMA of Quinnipiac University at the Nurse School of Medicine, we will be presenting to you this panel. Today, we will be discussing health disparities that affect minority populations, which are an important aspect of public health. These conversations will be academic, social, medical, and rooted in research, as well as clinical experience in an open forum. Our planning committee consists of Mr. John Garcia, Shanae Green, Madison Masters, and Lillian James, who are all MD candidates at the Netter School of Medicine class of 2024. Myself, Dr. Olutayo, and Dr. Listy Thomas. Our lives begin to end the day we become silent about things that matter. Our panel discussion overview for tonight will include an article, which we'll review with the students and panelists, followed by a panel discussion with targeted questions to our panelists. We will review a second article and do the same. We'll then have a question and answer session and an open forum at the end. Our panelists today. It is my honor to introduce to you two great physicians and colleagues. Dr. Jessica Abrantes Figueredo is the Chief Infectious Disease Physician at St. Francis Hospital. She is board certified in infectious disease and internal medicine. She received her medical education at the University of Connecticut School of Medicine, did her residency also at UConn, and did her fellowship also at UConn. Along with treating patients on a daily basis, she serves the greater community with several educational and advocacy positions and leads the hospital's Antimicrobial Stewardship Center of Excellence. She was named Chief of Infectious Disease at St. Francis Hospital in July 2020, in the midst of the COVID-19 pandemic, and she helped establish the drive-through testing program. It is an honor to have her with us today as one of our panelists. Thank you so much for being here with us. Next, we have Dr. Giles. Dr. Giles is a board-certified family medicine physician who has a clinical interest in the care of patients with HIV. She is originally from Birmingham, Alabama, and works in the Huntsville-Madison area. She earned her medical doctorate at the University of Alabama School of Medicine after receiving her bachelor's degree from Florida State University. She attended the UAB Huntsville Family Medicine Residency Program and is board certified by the American Board of Family Medicine. She served in the military for 3 years, caring for our armed forces, men and women, and their families, as well as military retirees. After completion of her service, she practiced in Texas before finding her home in Alabama. Prevention, stabilization, and reversal of chronic diseases are her true passion. She believes that the practice of medicine centers on helping patients live their healthiest life through education, treatment, and encouragement. Thank you so much for being here, Dr. Abrantes and Dr. Giles. Thank you. Next, I would like to introduce our student moderators. First, we have Ikianosen Ukwedoba, who is candidate class of 2025 at the Netter School of Medicine and the recently appointed SNMA Vice President. Congratulations for the upcoming year. We also have Madison Masters, who is MD candidate class of 2024 and is the current SNMA chapter treasurer. We thank both of them for being our student moderators today, and I'm actually going to turn it over to them. Take it away, ladies.
Thank you, Dr. Segunro. So just to open, research in the US has found that there is little difference in sexual behavior between white women who have sex with men and Black women who have sex with men. Yet Black women have far higher rates of STIs than white women do. In 2017, the rates for Black women were 5 times higher for chlamydia, 8 times higher for gonorrhea, and 5 times higher for syphilis. Similar disparities in STI rates exist between Black and white men who have sex with women and Black and white men who have sex with men. And this was from Christine Shields, MSN, Dr. PH. She's a doctor of public health, women's health nurse practitioner, researcher, and writer on reproductive health and justice. So the first paper that we have is STD and HIV risk factors among US young adults. Sorry. Variations by gender, race, ethnicity, and sexual orientation, written by Sanyo Amajola and Bethany Everett, and published in Perspectives on Sexual and Reproductive Health in 2012. So in this study, the National Longitudinal Study of Adolescent Health was used to develop population-based estimates of STD and HIV risk factors among young adults in their 20s by the end of the study, with an N of 11,045. Patients were stratified by gender, race, and ethnicity, and sexual orientation. Importantly, in this study, mixed orientation was a term that was used to describe three groups of participants. So participants were asked about their sexual orientation by asking if they were 100% heterosexual, mostly heterosexual but interested in members of the same sex, bisexual, mostly homosexual but interested in members of the opposite sex, and 100% homosexual were the terms that were used in the National Longitudinal Study of Adolescent Health. In this paper, mixed orientation is used to categorize the middle three groups of people who may be bisexual or interested in either side. Risk factors that were studied include number of partners, forced sex, male or female condom use, incarceration, injection drug use, commercial sex, and self-reported STD diagnoses. Next there, thank you. For our findings in this paper, sexual minority women in all racial and ethnic groups and mixed orientation Black women had a higher prevalence of sexual risk behaviors than their heterosexual counterparts and were found to be at greater risk of acquiring an STD or HIV. There was no significant difference in heterosexual white and Black women's reported number of sexual partners, but Black women were significantly more likely to report having been diagnosed with an STD. Additionally, gay men and Black men of all orientations reported significantly higher STD diagnosis rates than heterosexual white men. And mixed orientation Black men and Black women were at particularly increased risks in all of the categories above. So for our first question, increased stigma around sensitive topics is a common theme noted in papers about healthcare disparities. And this paper also mentioned some potential effects of stigmatization as a factor in sexual and reproductive health in adolescents and young adults. So Dr. Giles, could you please tell us what are some ways that physicians can destigmatize the encounter for patients who are seeking sexual and reproductive health care? Are there frameworks already in place that we can use?
And thank you, Madison, for including me in this question. And that paper was actually very interesting. I did take an opportunity to read it. And so in regards to the question that you proposed, I think it's very important to focus on two things with patients. And really, you're kind of learning that in medical school right now. So one, be aware of your approach to the patient and your body language. And some of these things are going to sound like duh, but honestly, these things evolve as you practice, if that makes sense. So, for example, a patient will feel your energy when you walk in the room. If you're rushed because you have God knows how many people on your schedule, they're going to feel that. And they're probably not going to be so apt to be forthcoming with much information. If you are kind of dismissive or kind of nonchalant about their problems, they're going to take note of that mentally, and that may put up a guard between you and the patient. So just be aware of that body language. You get taught in medical school, come in, sit down. I have to be honest with you, that matters a lot to a patient. Instead of standing there trying to quickly do the visit because you got another like 2-3 patients to get to, taking that time to say that this is your visit matters immensely to them. Okay, so that's first thing and foremost. Second thing, word choices and how you phrase questions. Again, may sound very like minimal. I'm gonna give you just a very small example. A lot of times you'll discover that your nurse or your MA will like, have you had any change in your medication, when they go over their information before you go in. And that has to be one of the worst questions ever, to be honest, because you can have a patient that's on 7 medications. They don't know. but to take the time to go through each one of them and the doses and say, hey, are you actually taking this medication? When is the last time you took this medication? Matters way more than just this one question of any medication changes. So, for example, more towards to what we're discussing, I do not ask patients, are you gay, heterosexual, homosexual, bisexual? Human beings are one of the oddest things ever, because something that may seem like, okay, no, obviously you're homosexual if you have sex with men, but people don't necessarily identify themselves that way. So you have to kind of bring it down from a labeling approach, right? So when I ask them, you have sex with men, women, or both? Have you ever had sex with men, women, or both? And you just leave it open. And the way you say it and your demeanor in the appointment matters so much to whether or not that patient is going to be forthcoming with you, okay? And then two, a lot of times people aren't all that forthcoming with the first visit. It may take a couple of them for them to get comfortable with you, okay? So don't be judgmental. Don't be like, oh, well, you just told me this, and that. A lot of times patients will tell you as they keep talking. And you're like, well, you did just kind of tell me this, so I need you to clarify for me. What do you mean? One of the things in the study they mentioned was the condom use. And I thought it was odd how they used that, because they did not quantify that at all. They just said any condom use. They didn't say, as I like to pose to my patient, how often do you use condoms? Is it about 50% of the time? Do you forget quite often? Is it all the time, you never forget, or is it somewhere in between? Because with it, you get a little bit more information of, oh, I only use it with, my everyday partner, but if we see other people, I don't use them, or vice versa. I mean, I've heard a lot of stuff. So you kind of need to just remember to be open-minded, but also just be comfortable with the patient, and they'll be comfortable with you. The second thing is be inclusive about reproductive health in general, right? It's a system, just like everything else, just like the heart, the lungs, right? Reproduction is a system, so include it in your review of systems. Don't negate it. Don't forget to ask during the physical, do you have any burning, any itching, anything going on that you need to tell me about that I need to check? Because that may open the door for them to say, well, yeah, I noticed something, a discoloration, or I kind of have this rash. It may open the door for a sensitive topic that they probably would have never, ever mentioned to you before. So in regards to frameworks that are there, okay, again, what you're learning in medical school is very valuable. Take that to heart on how you treat these human beings that you've sworn to take care of, okay? It's kind of difficult sometimes. You can get frustrated. You have to keep yourself from getting jaded, okay? You have to pull yourself back from that era like, oh, people never change. Because what they don't add in the equations when you're learning how to treat different diagnoses is human error. You throw in human error into this medication plus diagnosis equal, no, you multiply times human error, and then you'd wonder why their diabetes or whatever is not controlled, right? They never took the medicine, okay? And you ask them why they never took the medicine, or they never came back for their second dose for their syphilis treatment. Why didn't you come back for your second dose? You had to do 3 doses, right? So it's that human error that you have to factor in. You have to keep yourself from getting jaded on, okay? Because you've been sworn to take care of people. So that training is very important. And then your EMR, a lot of times we get very frustrated with it, but it's very customizable to you and your approach, right? So if you want to make sure you're always checking for certain things, you're including reproductive health, you're including their sexual orientation, you can build it the way that you want it, right? But you have to be conscious or conscientious on including that for the patient. because again, it's part of the human body. And I think when they see that it's not a stigma for you, they're more likely to open up to you about it.
Thank you very much. So for our next question, gay, Black, and Hispanic men were significantly more likely than their white counterparts to report having been diagnosed with an STI and to report experiencing forced sex. And especially in the context of sexual and reproductive health, trauma-informed care is an important skill to cultivate. So Dr. Abrantes, how can physicians at all stages of their training incorporate more trauma-informed care into their practice? And what are some best practices we should be aware of for discussing sexual and reproductive health with patients of all sexual identities?
Thanks, Madison. So a lot of this actually goes back to even what Dr. Giles mentioned. It's really how you enter a room. Patients will remember that your mood, how you interact with them, the language you use, the judgment that sometimes gets passed, even from a physician, in all stages, and I remember back when I was reading this question, even when I was a medical student, and the errors that I made, even as a medical student, where, you walk into a room, it was the first time, Dr. S., you mentioned you were a surgeon, so it reminded me of my surgical rotation. And the chief was like, you can go on in, change the dressing. And I was so nervous that I literally just walked in, didn't even introduce myself, and just kind of said, I'm going to take off your dressing, not even asking consent. And I can still remember, and again, I was a third, fourth year medical student, that chief resident stopping me and saying, we always ask consent. And this was just to take down the dressing. And that really stuck with me in the setting of, we really have to make sure our patients feel comfortable. And you can learn that at all stages, at a medical student, fellow, resident, as an attending, and people are still learning too. A lot of the patients that I treat are these types of patients, right? They have STIs, or they have, HIV, Hep C, that already have so much stigma attached to it. And really, when someone gets diagnosed with HIV, Hep C, the first thing they think of is, I did something wrong, and that's their mindset. And usually in a lot of those new diagnoses too, some of them have been, due to forced sex or some type of trauma. And I really, mention to them and try to confide in them, you definitely do the sit down, make sure they feel comfortable, let them tell you as much as they can and they want to. And like Dr. Giles said, sometimes it's going to take more than one visit to really get them to open up. Something I do for my HIV patients, and even actually all of my STI patients, the thing about HIV though is, right, we don't have a cure. So these become our chronic patients for life. I really walk in the room when I know either they already know the diagnosis or I give them the diagnosis. I mention the first things first is, I want you to know that while there is not a cure, this is very treatable and you will live a happy, healthy life if we work together. And I talk about the stigma that, people obviously have. And, you see all these commercials now with all the new drugs out there that are trying to destigmatize some of these infections and diseases, but it's definitely still out there. And a significant disproportionate of these infections do certainly occur in Black and Hispanics, and typically, depending on the STD, based on some of your literature that you're showing us too, men more than women, but it's definitely out there. And again, a lot of it comes down to not being judgmental, the questions you use. Dr. Giles, I'm just like you with, do you have sex with men, women, both? And then I'll tell them, hey, I'm going to ask some personal questions. And the reason I'm going to ask them is because I need to know how and who you're having sex with so that I can help you, so that I can treat you. So I know what to test for, if anal, oral, vaginal sex, you have to ask these questions and in a non-judgmental way. It's the same thing with even some of these patients that I do see some patients who have, congenital HIV or some of these other conditions, again, from forced sex, which obviously to them then I got HIV because of a rape or something like that, it's going to be significant to them. So trying to help them through that, and, not asking pointed questions where it's, they know they have to answer correctly for you to then give them. So you don't say, you're taking your medicine every day, right? I'll usually ask, okay, we have you on, I don't know, Biktarvy, which is an HIV medication. And I'll say, within the past week, a month, how many times do you think you've missed the doses? And obviously most people, if they're taking their medicine every day, they'll say, doc, never miss a dose. And then a lot of times though, and even patients where I think they're well controlled, they'll actually say, you know what, doc, I missed a dose here and there. And then we talk about why it's important not to miss doses, what can happen. So again, it's really making that rapport with patients so that they open up and so that you can really treat them to the best. The one thing I will mention to all, especially the medical students, and I still teach this to my fellows, is you're going to work with a lot of attendings, a lot of residents, fellows, et cetera, in all different stages of their training, and take whatever from each of those folks that really, sings to you, points to you to say, you know what, I'm going to use that in my future practice. And that's what actually really helped me become the person I am today. Not just one attending, but just bits and pieces from everything that I learned throughout my career, even as a medical student too.
Thank you so much. I really appreciate that. For our third question, and the final one on this paper, so many papers on sexual and reproductive health disparities have language around risky behavior that can often feel like victim blaming and can make these already sensitive discussions feel more difficult. Relatedly, many people who are voluntarily unvaccinated feel that they are stigmatized as disease vectors rather than people. And the authors also suggested that Black women's disproportionate risk for STIs may be explained more by the sexual networks in which they are embedded, which tend to be racially segregated and characterized by relatively high community STI prevalence levels, and much less so by their behavior. So, Dr. Giles, how can we change the discourse to dispel some of these biases surrounding the epidemiology of STIs and other infectious diseases?
That's a really great question. And to be honest, that's going to take a lot of people. And when I say that, we in the medical community can do a lot to help our patients. But sometimes, depending on where you are or what, I guess, specialty you've decided to take on, you might be the leading factor in that. And so what I mean by that, so I'm family practice and I get to see people from birth to, older age. Unfortunately, I don't get as many peds because a lot of pediatricians, and love my pediatric colleagues, but they have a very important role, and schools have a very important role for helping us destigmatize the idea of sex, right? And sexual orientation. By the time you get to me as a young adult, you're still, most time, patients are still figuring themselves out. They'll identify one particular way and then give them a year and then they're identifying a whole nother way. And we understand that. Why? Because we're growing, we're evolving, and we're learning ourselves. But I think that process can be helped earlier if we just as a society would just grow in the idea that sex is natural, right? And for example, when Gardasil first came out, how many parents and teachers and even some physicians were against Gardasil, right? We in the medical community, for the most part, were all like, hey, let's do this. Cervical cancer, don't want to deal with it anymore. Can really get ahead of this thing. But how many people like, oh no, I'm not giving that to my child because, that deals with sex, right? And it's kind of mind-boggling because it's like, well, mom, you had to have sex for her to get here. So what are we really talking about here, right? That's going to take a lot of movement as a society, that I would say. But what we can do as providers is still kind of what I've already said, helping patients feel comfortable enough to be able to open up to you. It's nice when that can come from someone who looks like you, but we also need individuals to be able to provide that universal care, regardless of who's sitting in front of you, right? To dispel some of the myths that, someone's just hypersexual, or this is most likely going to happen because, he's MSM. We have to kind of get people to, one, correct those biases if we hear that come from a patient, right? If you hear someone say something in a way that's like, yeah, no, that's not true, provide the education, provide a handout saying, yeah, this is some further literature if you want to educate yourself more. But it still comes to your approach. Like, hey, have you had your vaccination for this? It's not about whether or not, you're having sex, eventually you're going to do that. But this is so that you don't end up getting cervical cancer, or at least you don't have advanced cervical lesions later. Hep B, I mean, we've been giving Hep B for how long, right? And it is weird how these things are treated differently, but yet are really the same. That one I think is just going to take a larger approach from the community. And I think that we're doing that. I do. I think as we grow as a society, I think that a lot of those walls are starting to come down, honestly.
Thank you very much. And before we move on, I just want to make sure to note, it wasn't mentioned earlier, but in case anyone has any questions for our panelists, there will be a Q&A session at the end. So please feel free to put your questions in the chat. And we'll have our moderators also make sure to get to those at the end too. And thank you very much, Dr. Abrantes and Dr. Giles, for your answers to the questions for this first article. And now I'd like to hand it over to my colleague, Ikenosa.
Hi. So the next paper we'll be discussing is Laboratory Perspective on Racial Disparities in Sexually Transmitted Infections. And this was published in the Journal of Applied Laboratory Medicine in 2020. This is by Joshua A. Lieberman, Chase A. Cannon, Laurie A. Barossa. This epidemiological study evaluated the prevalence of STIs in different populations with an emphasis on chlamydia, syphilis, and gonorrhea in the United States. Amongst women without a previous diagnosis of an STI, the ratio of incidence of pelvic inflammatory disease is 2-to-1 for Black women compared to their white counterparts. The rate ratio for incidence of chlamydia was 5.6 times greater for non-Hispanic Blacks as compared to their white counterparts. The rate ratio for incidence of gonorrhea was 7.7 times greater in Black patients than whites. Also similar trends in disparities are observed in cases of congenital syphilis, where the CDC data shows an increased burden of disease, with rates of infection being 5 to 10 times greater in American Indian and Alaskan Natives, and 6.4 to 24 times greater in Black populations. All of these show an increased incidence rate of STIs that disproportionately affect marginalized communities within society. Several challenges impact the access to STI testing and management. Publicly funded safety net clinics are major providers of family planning and expert counseling for marginalized populations, and recent decrease in funding to these programs results in a reduction in staffing, treatment options, and health services. The outbreak of COVID resulted in an increased demand for some of the same high throughput equipment required to routinely diagnose STIs. These higher strain on public health laboratories and decreased public funding for safety net clinics further contribute to the disparities in testing availability and health services for marginalized and racial and ethnic groups. So our first question is, the authors mentioned in their concluding remarks that the persistent health disparities surrounding STIs can not only be solved by improvements in laboratories, but also must be accompanied by data-driven public policy solutions. Dr. Abrantes, how can we as physicians or physicians in training advocate for changes in public policies regarding health disparities? How can one get involved in shaping public policy?
I think the first step is, seeing the problem and calling it out like it is, right? A lot of people don't realize such a significant disparities. Now, a lot of the studies that you guys have shown are well before 2000 or 2020. And it seems as though only because of COVID and the stark differences we saw even in COVID infections did this bring this to light. But this has been going on for years and years and years. So really just first things first is calling it out like it is and knowing that there's a problem. As physicians in training, seeing the problem and trying to advocate then, whether it's in your clinic, whether it's in your hospital, whether it's in your training, trying to actually, make change. I'll give an example. When I was in training in my HIV clinic, we didn't do anal pap smears. Now there's some controversy with that, fine, as far as guidelines go. But part of the main reason was that if it were abnormal, we wouldn't have someone to send them to. So like a colorectal surgeon. Well, I thought, and then the same thing happened actually where we're training or where I train my fellows now at St. Francis. And I said, well, let's change that. Let's fix the problem and not just say, well, we don't have it, so we can't do it. And we can't offer that to our patients. It's the same thing with, access for certain things for our patients, right? Some clinics don't put penicillin in their pharmacy because it's too expensive. And that actually even came up at our clinic. And I said, well, if we don't treat the patients, then who's going to treat the patients? So a lot of it has to do with, seeing what's wrong and trying to stand up and being involved in education forums like this in your group right now as well. I never actually did more of the public health with up until COVID. And actually I graduated fellowship from 2018. So it's not that I'm far out from being a fellow. But even being involved in our own department of public health, a lot of the departments, whatever state you might be in, same thing with Dr. Giles, she's in Alabama. They have lots of programs too. And it's like you mentioned, a lot of the funding that got cut, then that's going to continue this stark difference of access to patients. Something that I always try to teach too, going back to some of the other questions as well, when, why somebody doesn't do something that we ask them, why they don't take their meds, why they didn't get their lab work. Well, some people don't have cars. I'm sure everyone on this call right now has a car, has a cell phone. I have patients that still have to pay their minutes on their phone. So they might not even get the phone call to come back for clinic. So we have to ask those questions of our patients and again, in a non-judgmental way so that we can make sure we can figure out, well, then how can I treat you? I think one of the good things that came out of COVID too was actually the telehealth or even audio visits, because I have patients that have to take 2 bus trips to get to me at St. Francis Hospital. That's a lot. And if anyone's taking a bus, public transport here, I did when I was a little kid, that is tough. You got to be up early in the morning. So again, I think a lot of it has to do with education and, groups like this and seeing a problem and trying to fix it. I used to think of myself, oh, I'm just a fellow, so I can't make that much change. As a medical student, as a resident, as an intern, a fellow, people can definitely make change. And, getting into the right, niche or, contacting people that might have and might be able to help you to see your projects go forward, I think would be another great thing for people to do.
Thank you. Like Madison said, if anyone has questions, feel free to drop them in the chat as well. Our second question, the authors discuss how the history of racial inequality, discrimination, and experience of differential delivery of care can lead to mistrust in the medical system. Dr. Giles, how have you seen the impact of this mistrust on limiting the effectiveness of efforts to reduce STI incidence? What are some strategies to mitigate these effects and increase trust?
So in regards to this question, I have to be honest, and I really searched long and hard kind of mentally to see if I've ran into an incident where I felt like mistrust was one of the limiting factors on being able to be effective in treating or trying to reduce STI occurrences. And I really could not see where that was a connection with STIs. I've now social issues or barriers to care that I feel like ends up being way more prominent with some of the populations, particularly my population that I serve. Like Dr. Bruntis said, you're trying to call a patient, you just talked to them yesterday, and you're trying to call them back with the results, and you can't get them on the phone now. Or, hey, they don't have that ride to get to the clinic to even get treatment. So you're trying to work with the health department that's in their area to get them the treatment that they need. Or, just various barriers. They're sharing a car with someone else, and so that person took the car. I've seen more of that kind of impact on limiting the effectiveness in trying to tackle various STIs, particularly HIV. I would say that we're pretty privileged at the clinic that I work at, where we're able to go pick up patients if they do not have a ride. And our drivers will go pretty darn far. Sometimes it's patients kind of getting beyond their pride or even beyond their fear to either accept help, see our social workers to see if we can get issues, either food or place to stay. Sometimes they're homeless. We have a lot of resources, but sometimes it takes the patient saying, I'm open to this resource, or I need to let you know this is an issue that's going on in my life. So I've seen more of those barriers. And I'm not saying that I have not seen where mistrust has limited the effectiveness of a course of treatment or a course of action, because I did see that with COVID. I cannot tell you how many patients I had to try to help them understand, the vaccine is not going to put some microns in you or something, whatever they heard, trying to dispel that myth. That came up a lot during this pandemic, especially from my older African American patients, especially patients who still kind of remember Tuskegee and the experiment, and you're letting them know, yes, a lot of good came from that to things that we cannot do in medicine. And so you don't have to worry about that happening in medicine. And if for people who don't know what I'm talking about when they were allowing those individuals to suffer from syphilis, when they had a cure for syphilis. Some people still remember that. And I'm in Alabama. So, it's definitely strong here. Like, okay, do I trust what you're telling me? But a lot of times you can help that just by the things that I've already said. Sit down and talk to the patient. Give them that information that on their level, of course, right? You're not going to say this article and this percentage, but you're going to try to bring it to them where they understand. And you give them the opportunity to ask questions. You give them the opportunity to bring forth why they're hesitant. And you just give them the information. Let it sit, let it simmer. But you got to be able to sit down and have a discussion and not just talk at the patient. You got to talk to the patient and allow them to talk back to you. And that takes time. So when y'all get out there, I promise you some of these institutions, they'll make you feel like you got to be like this. But we got into this for patients, right? To care for them, to try to get them to live as healthy as we can get them to be. Don't let anybody deter you from that. And you try to navigate medicine in a way that you're able to provide that care.
Thank you so much, Dr. Giles. Our third question is the outbreak of COVID has disproportionately affected non-white and historically marginalized communities in the United States and continues to threaten healthcare access to sexual health services in these communities. Dr. Abrantes, what are some ways that the guidelines and recommendation for STI treatment and management in marginalized populations should change in response to the outbreak?
I think this again goes to access and how can we make it easy for patients to get the care they need and get the treatment that they need, right? We've seen it with COVID. I'll give you an example. Even me as chief of ID, when I had to go get my family tested, even I was struggling at one point where, oh my gosh, where do I go? And I'm like, wait a minute, I am an infectious disease physician and I'm having trouble finding out where I'm going to go get tested. What are my patients doing? And the same thing obviously goes for STIs too. I've had some patients that might have had, symptoms for weeks to months. You get a patient that comes in for secondary or even, late latent syphilis. And then they actually remember, oh yeah, I had a chancre on my penis a long time ago. I didn't go see a doctor, it went away. So then I said, forget about it. So again, I think part of it is making it easy for access to care. Something that our ER does a lot too is we treat right away. If someone comes to the ER or in urgent care, same thing with our clinics too. But again, it's just very difficult with obviously the outbreak causing such, not only showing the disproportionate affected, but like Dr. Giles was saying too, it also brought to light, the why so many folks might mistrust the healthcare community. So again, technically our guidelines can't change, right? We're supposed to use standard of care for certain medications to give our patients, but just making it easier for them to get. So we try to do that in our clinics, whether we give it same day. It brings me back to how some clinics actually don't stock penicillin in their clinics because of the expense. Well, I advocate obviously that we need it in our clinic. And then if we have PCPs or other docs around us that don't have it, sure, they might test, but they know that they can send patients to us. And in our clinic specifically, so I'll speak to our clinic too, I get a new HIV diagnosis, a new syphilis diagnosis, I review the case, and these patients get seen like ASAP. We're not talking a week, a month later. They get seen within a day or two. I honestly drop everything. I have usually one clinic day, but we try to drop everything so that we can pop a patient in and really connect them to care and get them the treatment that they need.
Thank you so much, Dr. Abrantes and Dr. Giles, for sharing such meaningful insights. I will now switch over to John, who will do the Q&A session.
Yes, thank you so much, Dr. Abrantes and Dr. Giles. I would like to introduce Mr. John Garcia and Ms. Lillian James. They will go ahead and ask our questions into the forum, and then we'll open it up for the open floor after that. Thank you.
So I'll just read some of the questions that were directed to me in the chat. And these are not directed at any specific panelist. If you have any comments, feel free to share. So the first question is, there are economic barriers to accessing HIV health services in the United States, especially in minority populations. Are there any organizations you recommend that we can refer patients seeking HIV care and any financial assistance?
Well, I know if we're talking specifically on HIV, there's Ron White programs still exist, and they still exist in most states. I mean, I don't think there's a state that doesn't have a Ron White program. Now, how robust that program is, now that's the part that varies from state to state. I feel like I'm very fortunate at the clinic where I am because they're able to offer a lot of services. And Alabama also decided that, hey, we're going to give all of our Ron White patients insurance. I mean, of course, they have to make sure they do the parts that they need to providing the social workers with the documents that they need. But that's an extra step that we have gone to in our state for that population. But yes, for our minority, underserved population, a lot of times it's hard to overcome various economic or social barriers to care. But there are programs out there. It's just a lot of times people get plugged into them either because of diagnosis at the ED or at the health department, and they know how to plug them into those round-white programs that are available across the state. So that's what I can think of. Dr. Brontes, do you have something to add?
Agreed. A lot of places have Ryan White. There's also in Connecticut the KDAP, which is essentially an AIDS drug assistant program. So really, there's never an issue with getting our patients the drugs. Honestly, the issues I sometimes have is with patients who have like private insurance that just for some reason they are ridiculous with wanting to kind of jump through hoops to get people treated. The other thing is a lot of these drug companies, a lot of people talk about big pharma, but most of these drug companies have coupon cards and work with us and say, you know what, your patient can go through our drug company to get the coupon card, X amount gets covered, and then we always find ways. The other great thing, Dr. Giles, you had mentioned this before, having social workers, case managers, and we have a social worker in our clinic. And I mean, again, these people are amazing at the things that they can help get done for us, for our patients. But yeah, there's definitely ways in getting patients their drugs.
And I second what Dr. Bruntis said. Sometimes it's the commercial insurance where you're banging your head against the wall. Sometimes it would be better for your patient, your round white patient, not to have insurance, so you can get them whatever they need. Versus them having their own insurance, and then there's like, oh, this is not on the formulary, and you're like, but it works. So yeah.
Thank you. So another question that we have is, can you tell us a bit about the limits on confidentiality regarding HIV reporting, aka reporting to Department of Health, notifying possible partners or contacts?
That might actually differ in every state, I think. So for any HIV, and I actually recently went into this both from the lab standpoint and then as the provider. So as a provider, when I see a new HIV patient, there's a form that we fill out for DPH so that they're aware. A lot of times, though, it's dependent on the patient too. I've had patients who are married and have HIV, and then I ask them, how would you like to notify your spouse or your significant other, your boyfriend, however it is? And sometimes they want me to bring back that person and then tell them, that way. Other times people want to remain anonymous. So I just tell them that, it's my obligation to, write out the report to, DPH, and then they help anonymously contact any contact so that they might get tested as well.
And here in Alabama, I mean, our public health department is like always on it. They're typically aware of the HIV status before we lay eyes on the patient, to be honest. And they're already doing that contract tracing. I do still provide some education to the patients on that, because you have some patients that are nervous about, well, I don't want it to come back to me. And I'm like, well, somebody gave it to you, which means they have been sexually active with somebody else. So just be honest and forthcoming. But sometimes my patients will let their partners know themselves. And that has been received positively, letting their partners know they need to be tested. But they just have that open rapport with their partners like that. So
Thank you so much for those great answers. I would like to go ahead and open up the floor and open up the forum. If anyone has any questions they want to ask directly to our panelists or any comments they want to make, please feel free to unmute yourself and go right ahead.
I had a question. So for Dr. Giles, it was really interesting to hear about the kinds of services you could provide to your patients, like drivers who can pick them up. Can you describe what kind of practice you work in, what the location and setup are?
Sure. So I work at a federally qualified health center. They were originally Brown White solely, and they were an FQ lookalike, but they recently got their FQHC status it was right before the pandemic started, so about 2019. And so we are in the heart of the city of Huntsville. Um, and so, like I said, they started off as a Brown White program, so they already had that as their basis. But once they became an FQHC, that opened the door for a lot more primary care. And so that's what sold me to join on board, because I've always had an interest in HIV, but I can also kind of keep up with my primary care. And they serve a pretty large underserved population here. And I have to be honest, the Ron White program is just really robust for everything that we're able to provide those clients, from rental assistance to so there's actually one particular housing unit that they can help patients get into. There are certain qualifications for it. And then again, assistance with medications, assistance with getting in to see specialists for certain things. So I'm pretty proud to be associated with this program. Did I answer your question, Madison?
Yes, thank you.
Okay.
I have a quick question. Both of you have mentioned the Ryan White program. Could you share maybe some more information about it, and where it started?
Yes, so Ron White started back, I want to say it was the early 1990s. Please correct me, Dr. Bruntis, if that's not right. It was either late, I want to say it's the 1990s, from a patient, Ryan, who was diagnosed with and passed away from HIV. I want to say he was a hemophiliac, if I'm not mistaken. And so he pretty much, so just a little backstory, HIV, came on the scene early 80s, really frantic. No one knew really what was going on. They could tell that it was like sexually transmitted, but you also had babies being born with it. And so it was just a lot of confusion. They were trying to figure out what the virus was, able to figure that out. However, kind of like with COVID, somehow infections and science and diseases become political, which they never should be. And it was kind of hush hush, and people were taking their own, I guess, assumptions about the virus. So, it only affects homosexuals, which was never true. And so you had some people walking around like, okay, I don't have to worry about this, but that was never true, right? And so there were a lot of people who suffered from that misconception that was allowed to grow in our country without being checked. And so Ron White, he ended up passing away, and a lot of people lobbied behind him to say, hey, we need to have a change. And so that opened the door to treatment and other funding options. A few years ago, they thought that it was going to go away, I think, with the advancement of the marketplace, or something was going on, and some political stuff was going on, but it's still alive today. And I mean, sometimes I can give my Ryan White patients, my HIV positive patients, better care than I can those who come to me uninsured and HIV negative. The amount of resources that provides is pretty awesome. And it's federally funded, correct, Dr. Bruntis? But the states kind of navigate.
Yeah. And there's rules and regulations, right? So, with some of my Ryan White patients, we kind of have to make sure we check X, Y, and Z. And then, so it's a little bit different. But again, a lot of resources that we have for these patients.
Wow, thank you both so much. If not, I would like to say thank you so much to everyone for participating tonight.
There was one question that just came in.
Yeah, please go ahead.
So this person asks, have you come across barriers associated with religious beliefs impacting treatment modalities?
I actually have had this happen only once. And, just like sometimes we have, anti-vax believers, it was a sad case of, and Dr. Giles, correct me if I'm wrong, but we rarely see AIDS nowadays, right? Our treatment is so good that you don't see AIDS. And, a lot of our patients might be religious, but it typically hasn't been an issue with impacting treatment modalities. They accept treatment. It was just one very unfortunate case, advanced AIDS, young gentleman who also had ended up having anorectal cancer, and his parents and himself had a lot of religious background and really thought that they didn't need treatment even for the cancer. And that was very difficult to watch, no matter how much people tried to explain and see their views and then them hear our views too. It really impacted him, obviously, because he did not want treatment and then ultimately died. That one still sits with me. That was, I think, my first year as an attending. So again, sometimes it happens. It's rare because most of our patients, even if they are religious, then accept treatment. The patients that may sometimes question, well, I'm religious, so my priest or pastor or whoever, they're gonna, shun me, and so we always swing it, just like with a lot of other conditions too, right? Well, if you do believe in God or whoever you believe in, God made these treatments so that you can get the help. We always try to use that and, help them see that this is really what they need.
I agree with Dr. Bruntis. I have not seen religious beliefs negatively impact HIV treatment. I would say I see more so mental health, like a mental block, mental barrier that negatively impacts the treatment. And she's right, like you rarely see AIDS these days. And if you do, for a fact that that patient has just been non-compliant for a while. And I just lost a patient a month ago who there was just this mental block. And I tried my best to try to get beyond it. And we also have a psychiatrist that our HIV patients can see. And we also provide counseling. And so I was trying to get him maybe into that, just because I wanted him to live. And that's one thing that you're going to learn to a medicine. You may want something way more than the patient, but the patient is the adult. And at the end of the day, they're going to do whatever they're kind of set on. And he would not go to counseling. I really feel to this day, if he had just accepted counseling, we probably could have gotten beyond this disconnect he had. He was like, sometimes I just want to live for the moment. And then sometimes, I want to really live. And so he was just on and off of these meds. And yeah, that was a tough one. That was a hard one, but we just could never get him to accept further help. So I would say definitely a lot of times fear or mental barriers actually block patients with treatment more so than any religious belief.
That was a great question. And great answers. So thank you all. I would just like to say thank you again to our panelists, Dr. Abrantes and Dr. Giles. Thank you so much for coming tonight and enlightening us with all this information, from how to act as physicians and future physicians, and also those people who take care of and support patients who have HIV and other sexually transmitted infections. We thank you so much for your time this evening. And thank you everyone who attended and was, very attentive and just great questions. I would like to just take this time to say that our next and fourth event for this and final event for this season will be next month. It will be on April 21st at 7:30 p.m. We'll be having a speaker Mr. Mark Abraham, who is the Executive Director of Data Haven in New Haven, Connecticut, which is partnered with the Urban Institute in Washington, D.C. And we'll be talking about data for community action, the importance of understanding local health inequities, and we'll be using Connecticut as the focus. So it will be a great talk. We're going to have some dialogue and some open forums for us to all kind of interact and talk about some of our experiences and some of our wishes for changing the future in regards to health disparities. So I really hope to see you all there. We will send the flyer with the follow-up email to this event. In the meantime, I'm going to turn it over to Mr. Garcia to give us our closing thank yous and let us know about the survey.
Thank you, Dr. Seguinro. Just to mirror that, thank you everyone for joining us. Thank you, Dr. Abrantes and Dr. Giles. If you can just take a quick minute to fill out the survey for us, you can use your phones and scan this QR code. It's just going to give us an image of, what can we do to improve, and if the panel is doing what it's supposed to do, and gain some knowledge for from our panelists. So take a quick minute. The link will also be emailed with the email that you used to register for the event. So if you can please take a second, that would be great. And thank you everyone for joining us.